is to discuss about the HER2 positive metastatic breast cancer, how we sequence treatments. These are my disclosures. Since we discovered the HER2 pathway in 1980s, we could see that it was a very aggressive disease. At the moment, you just had chemotherapy, you didn't know much about it, and you know that this pathway is related to self-differentiation, migration, apoptosis, angiogenesis. So it was a very aggressive disease. But fortunately, since then, we found many drugs that can help and improve the prognosis of our patients. We have drugs that block the extracellular domain, like Trastuzumab, Pertuzumab, TDM1, Trastuzumab Deruxtecan, CD9085. But you also have small tyrosine kinase inhibitors that block the inner part of the receptors. It's another mechanism of action, Lapatinib, Neratinib, Tucatinib. And I'm going to talk how were the improvements made in the metastatic breast cancer setting with these drugs. And what's interesting to see before you move to the trials is how the overall survival of those patients have improved since we discovered these drugs. As you can see, in 2008, the median overall survival was about 39 months. In 2013, this was about 58 months. And you're going to see data from the CLEOPATRA, they are over 60 months. So it's very interesting to see that you can improve the outcome of these patients with these new treatments. Start with the first line. At the moment they designed the CLEOPATRA, we had the chemotherapy and Trastuzumab as the standard of care. And it had already improved the median progression-free survival from 6 months to 12 months with Trastuzumab. And with the CLEOPATRA, the idea was whether chemotherapy with dual blockade Pertuzumab, Trastuzumab would be better than chemotherapy Trastuzumab. This trial with 808 patients include mostly untreated patients. Only 10% of those have been previously treated with Trastuzumab. And the final report at 80 years of median follow-up, it consistently showed an improvement in median progression-free survival with dual blockade Pertuzumab and Trastuzumab and chemotherapy. The median progression-free survival goes from 12.4 months to 18.7 months. So we're talking about over 6 months improvement in median progression-free survival. And what was impressive was the improvement in the overall survival. Here, the median overall survival goes from 40.8 months to 57.1 months. So we have a 16.3 months improvement in overall survival. And if you look into the right part of the slides, a landmark analysis, you can see that at 8 years, 37% of those patients are still alive. So these treatments really are prolonging the survival and improving the outcome of our patients. There was one question that was asked, and it was recently published, presented in San Antonio 2020, whether all those patients, they need the chemotherapy. And the design of the PERTAIN trial that had the final analysis now was for those patients, either they were untreated, they received the first-line chemotherapy, and then they are randomized to receive dual blockade with Pertuzumab, Trastuzumab, endocrine therapy, or Trastuzumab and endocrine therapy. In this trial, is a quite old population. 33% they are older than 65. About 70% of them, they have visceral disease, and almost 60% of them, they received some induction chemotherapy. And you can see the left-hand side of this slide shows the progression-free survival on the upper corner and the overall survival on the bottom corner, showing that patients who did not receive an induction chemotherapy, they had a slight benefit in overall survival, but not much, and no difference in progression-free survival. But for those patients who received the previous chemotherapy, the induction chemotherapy, you can see that median progression-free survival goes from 12 to 26. And from those patients, the median overall survival with dual blockade chemo and no chemotherapy induction is 64 months. So this trial shows that for some patients that are not fit for chemotherapy, you could start with endocrine therapy and anti-HER2 agents. It's not for the entire population, but for a small fraction of patients. Then we have the second line with Trastuzumab T-DM1. This was tested in the EMILIA trial, 980 patients. They were randomized to receive T-DM1, one injection every 3 weeks, or capecitabine lapatinib, that was the standard of care. This trial showed that in the median progression-free survival improved with the T-DM1 by 3.2 months, from 6.4 to 9.6 months. And also, the final analysis of overall survival showed a 4 months improvement in overall survival. Despite that 27% of those patients, they cross over from the control to receive T-DM1. So this trial really established T-DM1 as the second line of treatment. But we know that those patients, despite receiving dual blockade in first line or T-DM1 in second line, some are going to relapse, and you need to have new strategies and how we can improve the outcomes of our patients. One is using new tyrosine kinase inhibitors, like I mentioned, and I'm going to discuss the neratinib and tucatinib, or new ADCs like Margetuximab, B antibodies, I will not discuss because you don't have the results, and the new ADCs, antibody drug conjugates, this T-DM1-like, and I'm going to discuss 2 of them. So let's start blocking by the extracellular domain of the HER2 receptors. The first one was the Margetuximab. The Margetuximab is supposed to be a superpower Trastuzumab, and because it has more affinity to the CD16A and less affinity to the CD32B, so it would have less resistance and it would be more efficacious. And what the investigators did in this trial, 536 patients, they were randomized to receive Margetuximab plus chemo or Trastuzumab plus chemo. The first results showed a 0.9 month improvement in median progression-free survival. We have to recall that this trial, the patient population, 100% have received the dual blockade with pertuzumab, trastuzumab, and over 90% have received T-DM1. So it's a very modern patient population. But what was disappointing is just 0.9 months improvement in progression-free survival. And then it was recently published now in JAMA Oncology 2020. They did an update analysis with a slightly longer follow-up. The improvement in median progression-free survival is 1.3 months, and there was no difference in overall survival, 19.8 to 21.6. So it's quite disappointing that this drug that's supposed to be a super trastuzumab didn't improve patients' outcomes as we expected. A second drug, an ADC, the Trastuzumab Deruxtecan, that is a trastuzumab combined with a very potent chemotherapy agent. In this trial, phase 1/2, with 184 patients, they have been treated in third line or further. And here the median of treatment line was 6. So there were some patients up to 27 lines of treatment, which means it's a heavily pretreated patient population. What the investigators found was an impressive overall response rate of 61% and a median progression-free survival of 16.4 months. This is very impressive given the heavily pretreated patient population. The follow-up of this presentation was about 10 months. There was some cautions related to this drug, particularly the interstitial lung disease in 13.6% of those patients. We are trying to understand better who are the patients who are going to develop this interstitial lung disease. The investigators present now in San Antonio 2020 data with a longer follow-up, 20.4 5 months, and you can still see that the overall response rate didn't change, 61.4%. And the median progression-free survival increased from 16 to 19.4 now. And also what is interesting is the overall survival of those patients. The median overall survival is 24 months. And you can see at 1 year, 85% of the patients are alive. At 18 months, 74%. So it's a very efficacious treatment. And they looked also into the interstitial lung disease to see whether this was dose cumulative, which doesn't seem like. It occurs mostly in the first year of treatment and then remains stable. And this drug is being compared head-to-head to TDM1 in the DESTINY-Breast03 trial. We are waiting the results because if this drug is better than TDM1, it's going to take place as second-line treatment. Another drug, another ADC, the Trastuzumab Deruxtecan CD9085. We have data from a phase 1 trial. 50 patients, HER2 positive, heavily pretreated as well. They found 33% partial response and a median progression-free survival of 7.6 months. And based on these results, the FDA gave a fast-track designation for this drug for patients with pretreated HER2 positive metastatic disease. What you need to be cautious with this drug, it has some ocular toxicity that you don't understand very well who are the patients are going to get, and some of them, they are quite severe. So this is a caution that you should have with the drug. And this drug is being tested against physician's choice, so third line or further. It is going to be interesting to see if it's going to be better than the chemotherapy of choice. What happens if you want to block the intracellular domain of the HER2 receptor? That is another strategy to try to avoid this resistance. So today we have 4 molecules: lapatinib, tucatinib, neratinib, and pirtobrutinib. Lapatinib blocks HER1 and HER2. Neratinib and pirtobrutinib blocks HER1, HER2, HER4. And tucatinib is selected TKI for HER2. So these explain differences in toxicities and activity of these drugs. I will not discuss the data on the lapatinib trials per se, but I'm going to focus on these new drugs, tucatinib, neratinib, and pirtobrutinib. Particularly that they have some interesting activity in patients with brain metastases. Starting with tucatinib in the HER2 CLIMB. This trial, very interesting trial, randomized the patients to receive capecitabine, trastuzumab, tucatinib, or capecitabine, trastuzumab, placebo. The investigators were very smart because the sample size was 408, but they increased the sample size to demonstrate overall survival in patients with brain metastases. And this half of this trial population have brain metastases, and I'm going to discuss this as well. What the investigators found that there was an improvement in median progression-free survival. That was the primary endpoint of the trial with tucatinib combination. It goes from 5.6 months to 7.8 months with a hazard ratio 0.54. What is interesting to see is at 1 year, 33% of those patients treated with tucatinib, they are free of events, compared to only 12.3%. So a very effective drug in this patient population. They also look into the overall survival of those patients treated with tucatinib. And again, we could see a statistically significant improvement in overall survival, a hazard ratio 0.66 and 4.5 months improvement, absolute improvement in overall survival. If you look to the survival at 2 years, 44% of those patients treated with tucatinib are alive, compared to 26.6%. So again, demonstrate a very strong activity of this drug in pre-treated patients with HER2 positive metastatic breast cancer. And what was interesting here is to look for patients with brain metastases. They had almost 300 patients, 291 patients, who have been included with brain metastases. And what they found, that the median progression-free survival for those patients with brain metastases was improved from 5.4 months to 7.6 months. Again, demonstrating a clear activity in patients with brain metastases. And if you look at the curves at 1 year, patients treated with Tucatinib, almost 25% of those are free of event compared to 0 in the placebo arm. So again, very efficacious drug against brain metastases. They look into the overall survival of those patients. What happened to those patients treated with Tucatinib and brain metastases? Here, what you can see, the median overall survival is 18 months for Tucatinib, 12 months for the control arm. So 6.1 months improvement in overall survival. And if you look into 1 year, 70% of those patients treated with Tucatinib, they are alive compared to 46.7%. But what was very interesting to see in the brain metastasis patient population, here I described the all brain metastases, the 291 patients. So there was an improvement in median progression-free survival by 5.7 months. There is an improvement in overall survival by 6.1 months. But also, they looked into those patients who have been treated previously for brain metastasis. So brain metastasis treated and stable. Few patients, 117. There was an improvement in median progression-free survival by 8.3 months and an improvement in overall survival by 2.1 months. That could be what we call the prevention strategy. So we treat the patient, they do a secondary prevention. The other population with brain metastasis, they were treated and they had progression disease or they were untreated. So what happened here, 5.4 months improvement in progression-free survival, in 9 months improvement in overall survival. And then we look at a small proportion of patients with brain metastases that were untreated. Here you have to be cautious because you are talking about 66 patients. There was a 5-month improvement in progression-free survival and a 5.3 months progression, absolute benefit in overall survival. So again, this drug is very, very efficacious for patients with brain metastases. In San Antonio, in December last year, they also looked to the benefit of Tucatinib according to hormone receptor status. The hormone receptor positive on the left-hand side, the hormone receptor negative on the right-hand side. As you can see, both hormone receptors, they do benefit from Tucatinib compared to the control arm. If you look into the hormone receptor positive population, the 1 year progression-free survival was 11.3% in the control arm, 31%, almost 3 times higher progression-free survival. If you look into the negative patient, again, the 1 year progression-free survival was 15% in the control arm, 35% in the Tucatinib arm. So 2.5 more control in the hormone receptor negative. And if you look into the overall survival, again, there was an improvement in overall survival in both hormone receptor status. We can see a larger effect in the hormone receptor negative. The median progression, the 2 years overall survival goes from 17 to 51, so it's a 3 times higher. So the magnitude is, but it's still, you can see a benefit in progression-free survival and overall survival in both subgroups. Of course, those drugs, they have a different mechanism of action. They have some particular side effects. And here for Tucatinib, you can see more diarrhea, more palmoplantar erythema, more nausea with Tucatinib compared to the control arm. You can also see more vomiting, stomatitis, and loss of appetite, and some liver function alteration. Most of them are grade 1, grade 2, but there are some grade 3 toxicities. So we just need to learn how to deal with the side effects, particularly the diarrhea. Another strategy, another TKI, is the neratinib that was tested in the EMILIA trial. The EMILIA trial included patients with 2 or more lines of treatment for the metastatic breast cancer population. 621 patients were randomized to receive neratinib capecitabine or lapatinib capecitabine. That was the standard of care at that moment. Loperamide was given with the first dose of neratinib, and then the investigators tried to be a little bit more aggressive in the diarrhea management from the beginning. The trial had 33% of the patients who have been treated with pertuzumab, trastuzumab, and TDM1. So does not reflect the current patient population that you have. Is a more selected, less resistant patient population, I would say. What the investigators found that the median progression-free survival was 7% for the control arm, against 16% for neratinib capecitabine. But if you look in the absolute median progression-free survival, the survival is similar, 5.6 to 5.5. But what the investigators looked was a restriction at survival at 24 months. And there was an improvement by 2.2 months, and this led to the FDA approval of this combination. Duration of response was also higher with neratinib, 8.5 months versus 5.6 months, but there was no overall survival benefit. Here, they also included a small proportion of patients with brain metastases, 101 patients, and they analyzed the progression overall survival according to the brain metastases. So, as you can see on the left-hand side, the median progression-free survival for patients with brain metastases receiving neratinib was 7.8 months compared to 5.5 months in the control arm. So again, showing benefits for patients with brain metastases. The overall survival was very similar in both treatment arms, 16.4 versus 15.4. Again, these drugs, like all TKIs, they have some side effects like the diarrhea and the nausea, and there are some others very similar to Tucatinib. We have to be careful, and you really need to manage this diarrhea. For the neratinib, there are some studies looking for the increase of the dose. We start with a dose 160, then go to 200, then go to 240. So with this, you can decrease the diarrhea grade 3. What are the new combinations of strategies for HER2 positive breast cancer? And I'm going to mention 2 of them briefly. One is the immunotherapy. The first trial was the PANACEA trial, published by Shirin and Loy in 2019. Is a trial patient population heavily pretreated HER2 positive who received the pembrolizumab and trastuzumab, no chemotherapy. There was a proportion of patients PD-L1 positive and a proportion PD-L1 negative. What you could see, the overall response rate was 15% in those patients with PD-L1 positive tumors. So you can see an activity of this combination PD-L1 positive. And if you look in terms of progression-free survival, they were very similar, independent of the PD-L1 positivity, 2.5 months in PD-L1 negative, 2.7 months in the PD-L1 positive. But if you look into the overall survival, it's very nice to see that the PD-L1 positive has a better overall survival compared to the PD-L1 negative. So this gives a hint that this treatment could be effective in some patients multi-treated who do not require chemotherapy, but for the PD-L1 positive patient population only. This was also tested in the HER2 trial, where the investigators combined TDM1 Atezolizumab or TDM1 placebo. 202 patients. 20% of those, they had at least 3 lines of therapy, 58% 1 line of previous therapy. And hormone receptor was about 60% hormone receptor positive. What the investigators found in the median progression-free survival was slightly better with TDM1 atezolizumab, 8.2 months, compared to TDM1 alone, 6.8 months. It did not reach statistical significance, but when you look at the progression-free survival in patients with PD-L1 positive tumors, there you see a higher magnitude of benefit. The TDM1 alone is 4.1 months, the TDM1 atezo, 8.5 months. So again, demonstrate that patients with PD-L1 positive, they tend to respond better to immunotherapies. And they looked into overall survival. Here is difficult to draw many conclusions because the trial is small. But again, you can see that the median, the 1 year overall survival for patients treated with TDM1 atezo, TDM1 placebo was very similar, 89%. And if you look into the PD-L1 positive population, there you can see a slightly better outcome for patients treated with atezolizumab TDM1, 94.3 versus 87. Still, number that is small, is difficult to find a statistical significance. The last strategy that I want to talk to you is combine CDK4/6 inhibitors in patients with a triple positive ER, PR, and HER2 positive breast cancers. So this was tested in the phase 2 MonarcHER trial. Patients with at least 2 lines of prior anti-HER2 therapy. Through the real they could never receive the CDK4/6 or fulvestrant, and they should not have brain metastases. It's a phase 2 randomized trial, 237 patients. They were randomized to receive abemaciclib, trastuzumab fulvestrant, abemaciclib trastuzumab, or trastuzumab versus chemotherapy. And here, one problem that we have to highlight is from the beginning, the sample size calculation. Here they accept 80% power at a two-side alpha of 0.2. The 0.2 is quite large to accept this. So this should be a little bit smaller. And what they found, let's start with the right part of this slide. Patients treated with chemotherapy and trastuzumab, they have an overall response rate 13.9. Patients treated with abemaciclib plus trastuzumab, the green bar, they had a response rate 13.9, so very similar to chemotherapy. And those patients treated with abemaciclib, trastuzumab, and fulvestrant, they had almost 33% overall response. So there is a huge improvement in overall response with the CDK4/6 inhibitors. And if you look in terms of progression-free survival, this trial was statistically significant. It showed that if you look into the chemotherapy arm, the median progression-free survival was 5.6 months. In the arm B, trastuzumab and abemaciclib 5.65, and the arm A, 8.33. So almost 3 months improvement without any chemo, just combining CDK4/6 inhibitors, trastuzumab, and endocrine therapy. This is an interesting strategy that is moving forward even in the neoadjuvant setting. There are some trials testing this combination. So to finalize this part, what is the proposed algorithm that you have for sequence of treatments today? I think the first line treatment is clear. We have to go for a taxane-based chemotherapy, trastuzumab and pertuzumab, dual blockade based on CLEOPATRA trial. The second line today is CDM1. And then third line, assuming that you have all drugs available. Trastuzumab Deruxtecan showing a huge improvement, a huge response in heavily pretreated patients. You are waiting results of the phase 3 trial trial, but hopefully it's going to be positive. Then you have Tucatinib, capecitabine, trastuzumab, particularly for those patients with brain metastases. It shows improvement in median progression-free survival, overall survival in the whole population, and in the patients with brain metastases. And then you have neratinib capecitabine that demonstrates a small benefit in progression-free survival, no difference in overall survival. Margetuximab, again, a small benefit in progression-free survival, no benefit in overall survival. And then after that, we have the possibility of giving trastuzumab, capecitabine, trastuzumab, lapatinib, to combine anti-HER2, and not proved yet, but if available, you could consider for some patients abemaciclib, trastuzumab, fulvestrant. I think the choice of our treatment is really going to be based on the magnitude of benefit, how efficacious the drug is, in special subgroups like the brain metastases, the side effects. You have to consider that Trastuzumab Deruxtecan can give some pulmonary toxicity, so we have to be careful in those patients who have previously experienced a pulmonary toxicity with other drugs. You also have to consider the diarrhea with Tucatinib and if you give neratinib, and also oral versus intravenous drug. What is patient preference? So this is a discussion with the oncologist and the patients, and this should be always discussed in a multidisciplinary team. Today is impossible to take a decision for the best management of HER2 positive metastatic breast cancer or early breast cancer if it's not discussed in a multidisciplinary team. Of course, you cannot forget clinical trials. Clinical trials is important. It's the only way that you can advance science. You can advance and improve the prognosis of our patients. So we are waiting results of Trastuzumab Deruxtecan versus TDM1. So maybe in some months, this is going to change this algorithm. One question that comes quite often, what do you do with those patients who have a short progression after trastuzumab or trastuzumab, pertuzumab in the adjuvant setting? Those patients, short progression, if they receive trastuzumab or trastuzumab, pertuzumab, those patients are really candidates to receive TDM1. But now the question that is becoming even more complicated is some patients are receiving dual blockade in the neoadjuvant setting, then they have residual disease, and they receive TDM1. What to do with those patients next? We still do not have this patient population, but this is something that is going to come in the next years. So then again, we have to consider which is the disease-free interval from the end of TDM1. I think this algorithm is something that you could apply if considering that all drugs are available. For the moment, I do not have Trastuzumab Deruxtecan, I do not have capecitabine, I do not have neratinib, and I don't have Margetuximab. So I go from the TDM1 to those other possibilities. And this is much in line with the ESMO guidelines, the ABC5 guidelines, which also shows that we should use dual blockade as first with chemotherapy. You may consider endocrine therapy as maintenance when we stop the chemotherapy. And one thing that is important that they mention is a discussion that we can have this during the discussion part is what is the optimal duration of anti-HER2 drugs when patients reach a complete remission. That's something that we can discuss. I don't feel comfortable stopping drugs. I tend to continue, but it's something that you are going to see more often. If the patient progresses after pertuzumab, trastuzumab, second line would be TDM1. So, and then if you progress Trastuzumab Deruxtecan, Trastuzumab capecitabine, and Tucatinib, particularly if they have brain metastases, other options, Trastuzumab lapatinib, Trastuzumab and other chemotherapy that has not been used yet, or Trastuzumab and endocrine therapy. one thing that's clear, we have to continue block the HER2 pathway. Even this was demonstrated very early on by the German group, and you know that now that you have to keep on blocking this. And here again, like I mentioned, for those patients progressing rapidly, you can go directly to the TDM1. Some patients that are not suitable for chemo, with a long disease-free interval, minimal disease, and hormone receptor positive, you may consider anti-HER2 drugs, trastuzumab, pertuzumab, and endocrine therapy. And I think that the design, the results of the PERTAIN trial that I showed highlights this. So for some patients that you cannot give chemotherapy, you may consider giving endocrine therapy and dual blockade. Those patients, they still have uneven progression-free survival and overall survival. With this, I would like to thank for your attention, and I'm happy to take questions.